hopefully you guys can see us, and we're streaming and we're off and running. So welcome to this episode of our EGP Learning Podcast, where we are going to talk to you about something slightly different than normal, aren't we, Andy? It's a little bit of an interesting topic that came up.
Yeah, well, on a similar theme, I guess. But first of all, live episode. We're both monitoring the chat, so please ask questions, contribute. If you've got something to say about the topic, then pop that in the chat box, and we will bring it into the conversation.
Definitely.
Yeah. So what are we talking about today? So we normally look at an item in the news, don't we? And I think what counts as news these days is becoming more flexible. And I think social media counts as news, doesn't it, Gandhi?
Definitely. I mean, I often say to many people that, social media is one of the best ways for you to get hold of information because it's live, it's rapid, and as long as you can wheedle through the fake stuff, it can be really effective.
So we're looking at an issue, a topic, a conversation that occurred in the NHS Digital Whats App group today. So yeah, Gandhi, what came up? What was interesting?
So it's an interesting discussion because in the next week or so, NHS England are meant to publish a document that explains their perspective of how appointments work, particularly in general practice. And this spearheaded a massive discussion about what exactly constitutes an appointment and how we account for appointments as well. And I think partly this is probably to try and capture an element of demand. Obviously, post-COVID, we've seen loads of changes that have happened in the health service and especially in general practice. And if we're trying to understand what actual demand looks like, well, we need to kind of understand how we see people, what that counts as, and with us shifting to new ways of doing things, it's a bit different, isn't it, Andy?
Yeah, so the conversation sort of went in two directions, really. So there is this document coming up, and actually it's been alluded to previously in previous policy documents that have come out. And what is expected to happen is that NHS England or NHS Digital will be able to work with those people who provide our clinical records management systems, so System 1, EMIS, the others, and actually have direct live access to activity information about what's happening at an individual practice level. What types of appointments are being delivered, when are they being delivered, and how many are being delivered. And this led to, two bits of speculation. So there was a lot of concern and interest and discussion about how that data might be used and whether it be used appropriately. And then also people started talking about their own appointment systems and what they're doing, what they're counting, and how they're managing those on the ledgers of the appointments and the rota ledgers of clinical records management systems. And it was a really interesting discussion to watch and read. So where shall we start, Gandhi?
Well, I guess the first place I would probably suggest we start is what exactly constitutes an appointment, really. It's weird, isn't it? Because people think of an appointment as a one kind of thing, and it's not necessarily, is it?
No. I think people traditionally know what they feel constitutes an appointment. And I think an appointment traditionally would be, obviously a face-to-face encounter. I think that's been expanded successfully to include telephone appointments.
I think now we've got 4 different types of appointments, haven't we, effectively, when we talk about with patients. We've got the newer version, which is the online consultations, which I know some practices have been doing for several years, but in terms of the mass use of this, it's only happened really in the past few months. So that's online or notification-based consultations, whatever you want to call them. You've then got your telephone consultations that increasingly many patients will have experience of, and definitely clinicians will do. The other new one, which is video consultations, which again, some places have been doing for a few years, but actually mass uptake happened as of April this year. And then the traditional face-to-face appointment. And we've effectively got those 4 ways of contacting people, haven't we? And it's trying to understand what works best for which particular reason and for that individual patient as well. There is definitely that element that has to be taken into account.
Yeah, and also, but not all work is necessarily covered by those appointment types. And I think this is where a lot of practices and clinicians on the chat had some concern. Because there's all sorts of other useful things that go on. Sometimes we're providing second opinions for one another. Sometimes we're, supervising junior colleagues. And there's probably a bit of a question mark about how you classify a lot of the administrative type work that a lot of that GPs have to do a lot of and do a lot more of now than they did perhaps, 5-10 years ago when we were starting out. And that's things like processing documents, letters, queries that come from other professionals or that are generated within the practice, which is also work.
And prescriptions. Let's not forget those. Yeah.
Probably let's not forget those as well.
Yeah. Go on, Andy.
I was going to say, so what do you think people were worried about? Because this conversation was coming from a place of worry and concern for a lot of people. Where do you think that was coming from?
Well, I think the concern comes is that people count workload in completely different ways. There is no uniform way of saying what is an appointment, unfortunately. Many people say, well, an appointment is a contact with the patient. Well, what exactly is contact? Is contact reviewing the notes and making a clinical decision based on that? Is contact physically having the patient in front of you? What about telephone? What about online? These all take up time. And I think one of the real challenges we've got in general practice is that the amount of time that we spend doing things is never really accounted for. It never has been. Our capitation-based system that we have, which is basically general practice gets paid a set amount to offer care to patients for a year. And that amount changes. I don't know what the current amount is. I think it's something like £150 average per year, which is less than what most people pay, for example, for a Sky subscription or for a mobile phone contract.
Yeah, or to insure your hamster.
Yeah, that was one of the other ones, wasn't it? Insuring a hamster, it actually costs you more to do that than it does to receive healthcare in this country for a GP practice. But for that level of, what exactly does that generate in terms of workload? Because at the end of the day, we can't keep working all the time. We've seen that's what was happening to the profession even pre-COVID, and that's why lots of things were coming into play, like network working and other kind of things to try and support general practice, because there was an absolute recognition that it was on its knees, and to a degree it still is, and things haven't really changed a great deal. It's just changed in a different form. But how do we account for time in general practice when there is no limit? Effectively, that's the real challenge. And I think NHS England, just like any organization, like to count things. They like to have something that they can say is a number, and the problem is that counting clinical contact is a really challenging thing, and the only way you can really do that is by having a ledger, and that's effectively what an appointment system is. But then again, what is that contact? So I think we're going to get into that.
Gandhi, why do you think NHS England want this data? What do you think's there? I've got my own opinions, but why do you think they're doing this?
So number one, they're a bureaucratic organization that likes things to count. I think that's a necessity. And then once you've got a number, you can use that as a comparison, can't you? That's the key thing. So where do we sit now compared to where did we sit before, or where do we sit in the future? Because then that's something that you can either, allocate funds to based on the amount of change that happens. And also you've got representation. It's hard to count the kind of amount of work that we do. And until we can do that, it's hard to say what needs to happen in order to either improve things or to make things work slicker and stuff. So I think that's why they want to count it, whether it's appropriate or not. That's, I think, where a lot of the angst on the groups have come out, is that everybody's definition of what we need to count and how we need to count is completely different, and it's also different depending on which perspective you're looking from.
Yeah, I think so. Counting things is really popular in public services, isn't it? And I think if you look at other areas of public spending, like in education, defense, I don't know, but there's all sorts of measures that they count, and increasingly that's what they do. And I think it's done with good intention. I think from at the outset, I think the devil is in the detail. But if you can count activity, then you can use that to allocate resources or reallocate resources, and there might be an argument that some of this, provided the information is of good quality, that it might allow reallocation of resources to primary care, even, if actually the true level of activity is greater than what is anticipated. And maybe they suspect this, but but the evidence is required to demonstrate there might be reallocation of resources. I think also government tends to be concerned with variability. and they worry that some people deliver on their contract well and other people don't. And I think that's often largely unfounded and misunderstood. But they might use this as a drive to reduce variability as well, which I think is interesting. I suppose just rolling on from that, I've used the word activity quite a lot, and activity isn't need, is it? It's not. Activity is not demand. So there might be a lot more demand than the activity that happens, because activity is based on resources, and you can only deliver as much activity as your resources permit, even if the demand is much greater. So actually measuring demand is also important. I'd like to know what they're going to do about that. And then further, taking that further, is measuring need, because demand is not the same as need either. And really we should be allocating resources based on need and demand, then activity. So I'd really like to know how they're going to drive towards getting, data around those things. Maybe that's where the population health discussions and data comes in. Really, it's a really interesting topic.
It is, and I think there's loads of different tangents we could go on to. So there's the concept of access, which is always the one. I think, unfortunately, government-based organisations love to talk about access as a way of trying to understand how things work. The access agenda has always been there. How long it takes for you to see GP, and how long you have to wait to see GP, how many appointments is a practice providing versus how many, access in a hospital and that kind of thing. And I think it's something that they like to count. Unfortunately, if you ask many GPs, access is not the priority. Actually, continuity is, because we know that if you've got continuity of care, the outcomes for the patients are generally a lot more effective in terms of the quality of care and the outcomes of care that you get. But continuity is absolutely challenging to evaluate, because what do you constitute as a continuity? And it's because I think it is a harder thing for them to capture. They just go down the easier route, which is, well, how many appointments do you offer? That's what we're going to count, and that's what we think is a good thing to compare against, when actually, as you said, demand and need are the two parts that factor into that are not really captured at the same time.
Yeah, it's difficult. So I think other things people were considering, or that concern me about this potentially, is I like to think sometimes, okay, what's the best case scenario? And we've started to think about that actually the right data is collected, that it gives some indication of incorrect variability, and that can be addressed, and that's down to local and national leaders to address that with practices and so forth. That it highlights the level of work done in general practice on a whole, and perhaps gives a rationale for transfer of resources from secondary to primary care, and that perhaps even from areas of lower need and lower demand to areas of higher need and higher demand. And it would be great if that is what happens. I'm becoming more skeptical as I get older, Gandhi, and I wonder if actually something closer to the nightmare scenario. So I think what people might be concerned about is that actually the wrong data is collected, that it's used to, that a few areas that do well with particular models are held up as shining examples, and they try and impose those models around how to deliver things and what to count on the rest of the general practice ecosystem with disastrous results. Maybe some information might be leaked to the media about individual practices or groups of practices that have innovative access models that perhaps serve their populations well, but they don't tabulate well on the data collection. You can just imagine the Daily Mail might do with some of those things, that it's used incorrectly to reallocate resources to where they shouldn't be. Yes, there's all sorts of ways that this could go wrong. So I hope they're going to be careful in how they implement this.
And I think that's going to be the part of the challenge, isn't it? What if you had a patient who has multiple chronic diseases, but because of the innovative way that you do things, you try and capture all their chronic diseases in one clinical contact. So, for example, you offer them an hour-long appointment once or twice a year to deal with all their health issues, compared to 20, 30 minutes to deal with each of their individual issues throughout the year. That potentially could be 8 or 10 appointments versus 2. And if you don't have a mechanism for understanding the quality of that contact as well, then there's going to be a massive difference in the data, isn't there? And which one looks more effective is harder to judge just based on pure numbers. So I think that's one of the challenges we are going to have with accounting for what constitutes an appointment. And I think the reality, you cannot state what an appointment is, because a clinical contact can completely vary. We all know situations where what sounds like a simple 5-minute appointment for a common UTI can spiral into a case of that being actually a patient with potential, kidney cancer or something like that. And that has a completely different amount of workload compared to what may just be a common UTI infection. Does that make sense?
It does make sense to me. Yeah.
Mm-hmm.
Gandhi, so do you think this is, we talked about payment by results or payment by activity versus a capitation-based model. So we've got the capitation-based model at the moment.
Yeah.
Do you think this might indicate a desire to move towards a payment by activity model?
This has been one of the underlying debates that's run through the NHS and particularly general practice for many years now. General practice, as we mentioned earlier, is basically a capitation-based system. Your GP practice gets paid a set amount per patient per year to offer care. And there's an average number, and that varies. Some practices have less, some practices have more. I'm aware, I think about last year, it was approximately £156 per patient. How that ranks in comparison to the new PCN stuff and all the other investment that's gone in since COVID, I couldn't tell you. I don't think it's going to be significantly more, but it probably is a little bit more than that. But that's different to how other areas of the healthcare system are funded. So majority of hospitals are based on payment by results or payment by activity. And what that effectively means, for every little thing they do, there is a cost to the system that gets charged by the hospital. And one of the best examples of this is if you were to go to an A&E department, regardless of what happens, just you attending the A&E department will cost the system anywhere between, I believe, something like £60 to £100 just from you walking in the door. And that's in comparison to let's call it £150 for argument's sake, that your GP practice gets for your entire year of care, no matter how many times you go to the practice or make contact with the practice in that year. They don't get paid any more. There are certain things they get paid extra for if they do them. So, extra stuff like coils, minor surgeries, other kind of local enhanced projects and stuff. But effectively, your entire care is paid for in that one lump sum. So theoretically, if you went to A&E 3 times in a year, you'd cost the system more than an entire year of care by your GP practice. And that's part of the dichotomy that many people really struggle to judge and balance. And there's always this question of, should secondary care move to a capitation-based system, or should general practice move to a payment by activity system? Because actually, should we not have the same system no matter what part of healthcare you're in?
So I think what people would say is if secondary care moved to a capitation-based system, they would be bankrupt. And if primary care moved to a payment by activity system, I think the system would be bankrupt, wouldn't it? I think.
I definitely agree with both of those points. And I think that's the interesting dichotomy that comes with this, is that if you were to treat the entire system fairly, the bill for the system would be exponential. I think many people significantly underestimate the amount of work that happens in general practice because they don't see it. Patients don't see it. Managers don't see it. They don't see the amount of extra work that goes into it. And I mean, we're both partners in a practice. We work considerably more time in the practice than we are meant to. And that's not just us, that's every practice that goes. Very few places, I would say, people have the opportunity to walk in and walk out at the exact same time that they're meant to. And that's a real challenge to balance when it comes to how do you fund a business, because if you can't do that, then it's a problem, isn't it?
I always think the capitation model is a little bit crazy from a business perspective, and I'm not sure that many true businesses would sign up to that model of payment where you have no control over the demand and the required amount of activity that you'll have to do, and you have fixed costs. I mean, it just doesn't.
And I think the frustration that many places have with that is that the type of activity and demand that you have, for example, for an inner city practice compared to one in a nice leafy suburbs area is going to be completely different. That's not to say one is more than the other. It's just a completely different type of demand. So, for example, me and you both work in inner city areas. We have significant proportions of patients that are non-English speaking, that have deprivation as a key issue and a driver of their ill health and things. And that produces completely different challenges to how we offer them healthcare compared to a predominantly English-speaking population that's quite independent and able to do other things themselves. So generally speaking, if you ask them to do something for their health, they will understand the implications of that and be able to follow through with it a lot easier than someone that doesn't speak English, that doesn't understand the healthcare system and doesn't have the resources to do half the things you're asking them to do.
Yeah, here. We could have a separate debate on funding models for primary care, wouldn't we? I think a lot of us, provided it was set up correctly, I think payment by activity would make a lot of sense for GP practices, in terms of how they operate on a business, get paid a reasonable amount, an appropriate amount for delivering, a contact each time you have a contact. It's so much easier to match your recruitment, your staffing levels to the level of activity, to draw in additional staff to those areas where the activity is greater. It just makes so much more sense, but I think it would be so much more expensive for the taxpayer. So,
but then again, it comes back to that element of what you consider a contact. So, if we were to take a journey of a patient, that patient makes contact with the practice, and say they have a clinical health issue like a UTI. We've used that one already. First they will either have to make an online contact with the practice, or they will have to ring and speak to likely a receptionist or an admin person, and then they will either be signposted or navigated to a type of contact, whether that's automated, as in can be through a system based, so that the information provider says this sounds like a simple UTI, you can get your treatment direct from the pharmacy, we don't have to provide you with anything additional. If there's any further concerns, come back to us. Safety netting at the heart of that. Or it could be that ends up in a telephone contact with a GP, and that may be, or another member of the clinical team, doesn't have to be a GP. And then actually, there may be some additional things that come into that. Is it more complicated? Like we said, the example of actually a UTI that potentially has hallmarks of it being something more sinister, in which case then that's a further contact that they need. Is that a video consultation? Is that a face-to-face consultation they either need that day or later down the line? Further investigation, all those kind of things happen. And that's the journey of one contact. So are we counting the contact? Are we counting the workload implications that came with that? So, potentially 3 or 4 contacts rather than that one patient making access.
All good points. I suppose the commissioner commissions the service, and general practice will just flex and deliver whatever's commissioned. So, if and the commissioner has to be smart. So if they're paying by contact, and a face-to-face appointment is charged at a higher rate than an online appointment, then and that's all they do, I suppose every UTI is going to end up in a face-to-face appointment, because that's where the payment incentive is. They'd probably be better going for a system a bit more like hospitals, where there's I'm not quite sure what the word is, but there's a menu, and different things attract different level of funding, and a UTI might be charged at a certain amount, and abdominal pain at a different one. And maybe that's not the best example, because that might be a feature of UTI, but the payment incentive might mean that the provider is better off dealing with UTIs as an online appointment for the most part, unless there's a reason to escalate. And if they escalate, there's a more expensive option in the payment menu. Maybe we're getting a bit too much in the weeds here, Gandhi, but maybe.
But I think there is that element of accounting for the type of work you do. So I've been working in my practice for over 8 years now, and everybody logs the work they do completely differently. So for example, when I'm on call for the practice, every time I get asked to call a patient back because I'm on call, I see that as additional work I'm being asked to do. So I will log that as an appointment, partly just to remind me to call them back, because inevitably if I'm already with a patient, I can't really open up multiple records. That's not safe in my view. So, I will ask our reception team, stick it down as a telephone call or as an additional slot for me to call them back or to do that. So I've got a regular log of every single piece of contact I've done, whether that's a quick phone call, whether that's having to sort out a prescription for, the district nurses for that particular patient, whatever it is, I've got a log of that. And I make sure the log is appropriate. So if it's a telephone contact, it's a telephone one. If it's an admin contact, it's an admin one. Where some of my colleagues don't do that, they'll just do the work. They'll keep a list of the patient, but they don't log on our clinical system that's been an appointment. And that's the difference. That's the interesting part of this whole discussion. What are clinicians going to log? Because if that information is taken direct from our system, is there an amount of workload that is completely unaccounted for, or potentially double counted is the way you could look at it? And that's where this massive discussion spiraled into, I think.
Yeah, well, I think most practices will probably try and make as much work as visible as possible once they know where the counting is going to happen. So, Gandhi, before we move on, I just had a question about one of the appointment categories, and
Sure.
They'll probably provide more detail about what's appropriate to use it for. But I think the online consultation category has the scope to potentially capture a lot of this uncounted activity, really, because for me, what that seems to be describing is like an asynchronous encounter. So the patient, if it's synchronous, so that means people are engaging at the same time in the encounter. So that might be a telephone, a video, face-to-face. Asynchronous, they're doing something at a different time. So patient writes a message and then at a different point in time, or makes a request or logs a query with reception. And then at a different point in time, the GP responds and answers that. And I think that's really what's being described. And actually that covers really a lot of what we would now call uncounted work, And it's not just the patient, it's if their carer or another professional involved in their care has a contact as well. So, if that work is moved on to the ledger in a countable way, I think a lot of what is currently invisible will be counted. So I'm going to sort of be an advocate for smart use of the online appointment category, potentially, if it's counted that way.
As long as that data is also captured. So I think one of the concerns some people had is because those systems are provided by people that aren't the clinical systems directly. So obviously we've got companies like Ask My GP, Clinic, eConsult, whose system for delivering that is actually on a separate portal to the clinical records that we use, like System 1 and EMIS. Is that data actually going to be captured as well or not? Now, it has to be. If this is to work from NHS England's perspective, it has to be counted. But how they're going to count for that, that's the part that I don't think has been clarified yet, at the very least.
Yeah, it'd be a shame for practice to have to do extra work just transferring logs of these contacts, onto System 1. I mean, that makes no sense at all. So they'll have to integrate or find another way of capturing that activity data. So, Gandhi, what will the future of appointments look like? So a bit of a change of pace, but the conversation on the WhatsApp group sort of moved into discussions about what people are now doing in terms of their appointment systems, because COVID-19 has been a huge disruptor, as we've talked about, and things have changed an awful lot, with everybody being required to move to a total triage system for a period of time. And people are doing that in all sorts of different ways. What were your thoughts on some of the elements of that conversation, Gandhi?
Well, I think the important thing to remember is obviously back in end of March, April, general practice in the health system just completely changed because it had to. COVID came along and like you said, was the ultimate disruptor, as we've repeatedly called it. And as a result of that, for safety, for both for clinician and for staff safety, many practices changed the way that they were seeing patients. Be very clear, because there's a lot of fake news about this going around, that practices have still been running and still been seeing patients. I appreciate some people will feel that may not have been the experience they wanted, but they have been doing that. Let's be clear on that point. But how we continue to see patients, I think, will change, because many practices have now seen the benefits of using remote consultation methods like online consultation, telephone consultation, video consultations in place of everything being a default face-to-face. But I think one of the things we're going to see is how that works both for the patient groups and for the clinicians as well. Because I know there are many clinicians that feel that the old system is what they prefer because it's easier. There is actually a lot less mental workload when you see a patient face-to-face compared to when you have to deal with it online, because you're having to make multiple decisions when you're doing remote consultation that you wouldn't normally make when you're face-to-face with someone, because we're naturally, generally speaking, clinicians, and particularly those in primary care, we're trained to consult face-to-face, and therefore how we do that, picking up information and stuff, is a lot more natural and a lot easier for many clinicians, and therefore the workload is actually less intense. And you'll hear this from many of our colleagues. They've found that actually doing remote work is more mentally taxing than seeing patients face-to-face, because I think there's a significant higher decision load that comes with that. But
yeah,
how
I
that
I was just going to agree with you, Gandhi, and it's interesting how I've seen some of my colleagues, people have taken to it differently, and I think there's a personality element to what people prefer, but some people have sort of struggled more with risk management remotely. than others, or people who you perhaps wouldn't have thought would have had challenges, with risk management and how things sit with them after the event, have had those challenges, and that's just been really interesting to observe. And also the amount that people bring back from their telephone triage list, there's a lot of variability, which I think is interesting.
There is. And that's always going to be there, no matter how much education and training you give someone about how to do remote consultations, how you naturally communicate with people is always going to be your natural communication mode. And, some people are much more comfortable and confident consulting through a remote mechanism. Some people, for them, it has to be face-to-face. That is the natural thing for them, and that's where they shine. And actually, by switching, that's made it more uncomfortable for them, and therefore the desire to go back to the old system is much more prevalent. I think the interesting thing, which is one thing I've constantly been saying about, is that what we have and what we are going to see as a result of COVID is this right shift of patient demographics. So patients will be more comfortable using online mechanisms because they've got more comfortable using tech. Generally speaking, so a lot more of our population are doing things like Zoom calls, are doing WhatsApp calls, engaging through tech with their colleagues and stuff, and therefore we'll see the benefits of how remote consultation can save them time, because actually a lot of things could be more streamlined by simply just doing an online request or by doing a telephone request, rather than having to take a whole day out to come out and see the GP, or similarly for hospital-based care. I think remote consultations will massively change secondary care, particularly the outpatients departments. I think the ability for it to do that is going to be significantly exponential in terms of cost savings for the system. But how that works moving forward, I think a greater number of patients will be happy to accept that. But it's important. The one thing we don't know is what the outcomes are going to look like from this. So what about the missed cancers, the missed things that we haven't got because we haven't got that face-to-face element that we would have naturally picked up on something else potentially, because the communication is more challenging at times. And there is obviously those patient groups that will find remote consultation work so much more complex. So easy ones to think of again are the non-English speaking, the learning disabled patients, that kind of stuff, those that just don't like using tech, and won't use it.
Yeah, something interesting you just mentioned there, which it hadn't struck me until now, is the impact of electronic consultation on secondary care. And by electronic consultation, I think what I'm really meaning is structured information inquiry before the event of the consultation, because their encounters actually they're much more predictable, aren't they, than general practice. The hematuria clinic is the hematuria clinic. So they can. There's much more opportunity for it's an environment that lends itself much better, I think, to a focused inquiry of information prior to the consultation than perhaps GP consultations, which actually a lot of the value patients get from that is because of the free-flowing nature, and they come with one thing. And while I'm here, I'll tell you about the real thing that I'm really worried about. And that's much more difficult, I think, with the current crop of electronic sort of consultation.
I definitely agree. I think secondary care, the uptake of remote consultations, the amount of cost to the system it would change, but also the flow for patients and the experience that patients have would be so much more effective if a lot more of the work was done remotely. So for we talked about the hematuria clinic experience. Patients go to a hematuria clinic, so this is when they've got blood in their pee, because the GPs have found out that there's a problem there and they need investigations to look into that. There does need to be some history taking further to the information already provided by the practice. But actually, if you did that remotely, then there's the question of, do the patient need a physical exam, or do they need an investigation, or do they need both? And would it be more sensible to arrange that before the patient arrives in clinic for their face-to-face examination, because you're going to need to do some of those things? Or is it more effective that you see them, then request them, then bring them back to clinic? I doubt many people would say it's the second.
Yeah, of course, you can reduce the number of encounters significantly. So yeah, I've just not thought about actually the impact on secondary care, maybe more than primary care. I tend to be quite primary care focused in my thoughts.
It's not just that, it's the experience for the patient. Having attended outpatient clinics at hospitals, you normally have to take at least half, if not the whole day out of your life in order to focus around what could be a 10-minute contact, because you've got the added elements of getting ready for the appointment, going to the appointment, the parking. Oh my God, the parking at hospital is always a nightmare. If you're going by transport, then how you navigate that. the waiting, inevitably, you know, people complain about waits at GP practices. I've been to clinics where I've waited 3 times more than I've ever waited for a GP appointment. You know, I think my record is 4.5 hours wait for a clinic. You know, those elements become less of a concern and less of an issue. And estates is the big one as well. You suddenly open up the opportunity of using your estates more effectively, which I know what many practices are trying to do in the wake of remote consultation uptake.
Good. Right. So Gandhi, we could talk about
we could wax lyrical about this for ages.
I'm going to suggest that we don't, but I'm going to ask you, I'm going to take it to an extreme, and I'm going to say, is this for your practice? Okay. So probably the most extreme is not the right word, progressive system might be right. Everybody, or for the most part, obviously you'll make exception for the exceptional people with exceptional needs, but people generally, if they want an appointment, they will do an electronic structured collection of information. So some branching questions, you'll get some information about what does the patient want, what's the problem. That will be triaged by a clinician at the practice, and all of the encounters are going to go through a clinician. And that clinician is going to decide where they go within the practice. And they're going to decide what type of appointment they have with the individual that they go to. Is it going to be video? Is it going to be further electronic thing? You know, is it going to be telephone? And then the encounter happens, and it's done. And we're going to try and lean on technology. Is that going to? That's the most progressive. First, what do you think about that? It should be going that far, is what I'm asking.
I think ultimately, if we go down that route, it's going to be positive for everybody. I'll rephrase that: positive for the majority, because it streamlines the care and it makes it more timely for those individuals involved. I think there does need to be that accountant process of how that time is used, and obviously for staff, making sure that they're not having open-ended elements that make the workload just unmanageable, but also for patients that the responses are timely, and more importantly, the information to the patient is given in terms of how that time frame is going to work. You know, if this is urgent care that is appropriate to be delivered by general practice, then that may not lend itself to an online consultation, for example, because typically most online consultation mechanisms say that you've got a 48-hour window of reply, so you may not have a contact for another 2 days, and it's important to remember that. But then that's not the only pathway, actually. So we talked about that initial, you know, triaging element that could be, like you say, done by predominantly a clinician, GP, nurse practitioner, PA, you know, that kind of role. But it could be done by the systems themselves. You know, many of the clinical systems out there do offer digital triage, you know, to help patients understand where they need to be seen. And many practices will also use reception or admin-based signposting, or possibly even triage, which I wouldn't really recommend, to be honest. But signposting is different to triaging. It's really important to remember that signposting is suggesting to the patient what the best route may be and giving them the option, whereas triaging is here are your options, which are we going to take, not necessarily suggesting that there's more choice in that involvement and stuff. So there are those 3 different elements of how that workload goes.
Yeah, so I'm hearing you're fairly progressive in your views about appointments, and I think I'd be on similar ground to you, Gandhi, as well. Devil's in the detail, as ever. It's got to be successfully and well implemented.
Definitely.
But yes, exciting world we're potentially heading to, and I'm sure we'll be talking more about those topics in the future. Any final thoughts before we talk about the conference?
I think ultimately, you know, what we're going to see hopefully come out in the next couple of weeks is some guidance in terms of how this is all accounted for. I hope it's not going to be too prescriptive, because otherwise that's going to significantly limit the way that many practices run and operate, and that, like you said, will create false elements in the data. But I'm really interested to see what it actually does look like, what constitutes an appointment, how we document and count it. But I guess the big thing I would say to anybody out there that is listening to us, and hopefully there are a few people that actually do log the work that you're doing, you know, I think it's massively underestimated how much workload general practice actually does by everyone, even the people working general practice. And actually the only way that you can ever account for that is by logging what you're doing. It may be frustrating and annoying, but it's the only way you can create data that lets you move from one place to another, because inevitably you need to compare or contrast stuff. And that the only way we can do that is if we've got a number to count with. And, you know, this may be the way that we start getting towards that. way of doing things, hopefully more effectively.
So I guess what I'm hearing is it's coming. People will have access to the information about our activity, but let's embrace it, record everything so that we can show the value of primary care and what we're doing, hopefully make a good case for more resources in the future. And there's perhaps scope for use of the online category to log all the asynchronous work we've been doing for years and perhaps feeling undervalued for. So
definitely.
Excellent. Good. So that was an interesting discussion. And if people want to talk more about the use of clinical record management systems and how to use them effectively to log their activity and be more effective in their clinical work and care, wouldn't it be great if there was some sort of COVID safe online mini conference to address some of those needs in the population? Wouldn't that be great?
It would, wouldn't it? Do you know of any that are coming up, Andy?
Maybe. I don't know. What are you doing next Friday?
Oh, yeah. So in 6 days' time, Andy and I are hosting the System 1 Facebook User Group Online Summit, which is a conference with TPP System 1. And one of the specific sessions is about how you make your rotas and your appointments more effective. So about this topic, making it look and sound more sensible and appropriate, we've got a dedicated session on that. And I guess one of the questions we keep having is, what if I can't make it? Because it is a Friday, 10 till 2. Well, clearly, if you have a ticket, you can engage with the event directly. But the other thing is, if you do register to have a ticket, even if you can't attend, you'll get access to the recordings of all the sessions that we've got after the event itself. So you will still have access to all that information. You may not be able to engage in the same way. And we would love it if you could attend. And there's no problems with you dipping in and dipping out. You don't have to be there for the whole time. If there's a specific session that speaks to yourself, have a look at the schedule and stuff. But if you definitely can't attend but want the content, simply just register and you will get access to the recordings after the event as well. So we're creating a system whereby people have access to that priority access as soon as we've reformatted the videos and chopped and tailed them so it's more relevant to you and cut out all the stuff you don't need to hear. And we've got a really special surprise at the end, haven't we, Andy, that we've been working on. So nice.
The big finale, but you'll have to wait till the day to see what that is. But there's some great. I've got it on the screen, Gani. The schedule. Some really great sessions in there, and I'm looking forward to learning more about protocols because I want to build more.
Yes, so the protocols is proving to be a surprise hit, if I'm being honest. Look, so when you register, we do ask, what's your first and second choice sessions, and the top tips is definitely leading the pack, but I was surprised at how popular the advanced protocols creation session is in terms of what people want to attend. But we've got loads of stuff. I mean, we've got things about proxy access. We've got stuff about how to look at frailty. We've got a dedicated session on, QoF, the QoF guidance has come out recently and stuff. So we are tailoring this towards you. And we've got loads of excellent sponsors as well that are specifically designed to complement the work that many practices are doing with System 1 and stuff. So also keen to point out, if you are attending, have a chat with our sponsors. They will be able to provide you with loads of content and stuff. There's actually 8 different sponsors. I'm just about to load them all up this weekend and stuff in terms of the various different things and what they can offer and support you with as well. So we've got some really awesome content, hopefully, and we hope that everyone that engages and attends the event will have a really amazing time, good educational time, and get some awesome stuff as a result of joining us.
Yeah, and the platform looks awesome. This Hopin platform looks great, and I'm really looking forward to digital conference networking roulette. So there's a networking area, and you can every 3 minutes be switched to another delegate just to have some contact with. So I think for those people who are perhaps a little bit shy at approaching people at conferences, it might be an even better way to network. So I'm really excited to see how that feature works. So
definitely. And I think the other thing that we want to make clear as well, because it is a new system that we're using, we are trying our best to support all our delegates with how they use the system. So later on in the week, everyone that's attending will get an onboarding video that shows them how to use the system. And we've also got dedicated tech support for the event as well. So, and that will be outside of the Hopin platform through WhatsApp groups and that kind of stuff that's coming as well. So, if you are attending, we are going to try our utmost best to make sure short of you not having access to Wi-Fi, we're confident that you will have, a good experience and stuff. So hopefully that will work really well for everyone. And this dovetails onto our following thing that's the week after on the Wednesday, which is our NHS Digital First Providers Guide. So very on topic. We've got a session with Dr. Min Albakai, who's the Deputy Director of Digital First Primary Care for NHS England /I. And we've got 6 companies that are going to basically be showcasing what their digital first platforms look like. And we are offering you the opportunity to also have a look at them, but at the same time ask questions. And we've got some really awesome questions already submitted. If you've got some more, feel free to contact either myself or Andy to submit them. And this session, 29th of July, 12:30 to 1:30 live. Recording will be available afterwards if people want to watch afterwards, but clearly the opportunity of being live means you get to ask questions yourself, which is always awesome. And
yeah. I was gonna say, I think it's great because I think so many practices are in that position of wanting to go for one of these systems, but they need to just do some sort of evaluation and compare them. And I think this is like a really great opportunity to keep.
I think that's one of the reasons why we wanted to show this to you. We are going to show you 6 of the key systems out there. There's definitely the hope that we can do this for some of the other ones, and I've had contact from some of the other providers as well. So hopefully all goes well. We can do this again with some of the other providers to show you what other kind of systems are also out there and things. So, we hope that these will be some really amazing sessions that people can enjoy. Provide value to practices and stuff, and definitely if you're interested, just log on. I mean the Digital First Providers one is completely free. You just need to say you're going to watch the live stream and join us, basically. So yeah, looking forward to it.
Cool. So that probably brings us to a close for today. It's been a fun Saturday morning surgery, having a chat about all of these issues. And what's up next week? I think we're still finalising the content for next week, but there will be probably a version of a talk that I'm excited to be doing with some of the medical students at Bristol University next weekend. And we might we're going to be really busy with the conference over the course of the next week. But what we'll probably do is make a version of that talk, just looking at some of the recent COVID disruption and digital innovations around primary care, and just kind of giving an overview of all of those things that have happened and the topics. So that will be the content for next Saturday. So tune in 11 o'clock when that goes live and premieres. It'll be a recording, but you can watch it from 11 next week.
Awesome. So we hope everybody's enjoyed the session. We, as ever, love engaging with all of you. If you have been watching us live, thank you for doing so. If you're watching this after the event, feel free to contact us, whichever method you prefer, Twitter, Facebook, and LinkedIn, whatever. And as always at EGP Learning, we're here to help save you and your patients time by taking answering your primary care and learning. And we'll catch you in the next episode.
Bye, guys.
Bye.